Hello to all the viewers out there. I'm Gary Jesse, a managing director at Sellers Dorsey, and I'm joined today by two of my Sellers Dorsey colleagues and two of the most brilliant minds in Medicaid today, Lisa Allen and Mary Cantwell. Today we'll be discussing several key areas of Medicaid program administration. Lisa and Mary, how are you both doing today?
Doing well. Thank you, Gary.
Yes, thanks, Gary.
Great. Well, before we dive into today's topic, I want to provide some context for our discussion. This summer, the National Association of Medicaid Directors published a blog post that recognized the incredible workload Medicaid directors have, which obviously is no surprise to the three of us on this call today. But the blog post highlighted 5 key strategic initiatives and program innovations Medicaid directors wish they had more time to address. According to the blog post, Medicaid directors currently estimate they spend about 25% of their time working on strategic initiatives and program innovations. But in an ideal world, this figure would be closer to 40%. So today's conversation is the first of a 5-part series where we're going to dig into each of the 5 areas highlighted by the National Association of Medicaid Directors blog post as part of our ongoing Medicaid Matters blog. Today, we'll be focused on core program administration. We'll touch on the specific topics of value-based purchasing and quality improvement, as well as managed care procurement and oversight. We hope to give viewers more insight into these key priority areas based on our previous experiences within our own state Medicaid programs and recent trends and lessons we've learned as consultants helping clients navigate these topics across the country. So Lisa and Mary, are we ready to dive in?
Yep.
Let's get started.
Great. Well, the first area I want to talk about is value-based purchasing and quality improvement. So we know that state Medicaid programs continue to deploy value-based purchasing strategies to improve efficiency and quality within their programs. And more recently, with a greater focus on value-based purchasing as a tool to reduce disparities and increase health equity. CMS has signaled that value-based purchasing will be a key priority for the Biden administration. However, despite all of these efforts and focus on value-based purchasing at both the national and state level, many challenges still exist in moving the needles on value-based purchasing in Medicaid. Some of the challenges we hear about is balancing prescriptive programs and measures to align value-based purchasing across payers versus providing flexibility. How to structure MCO contract requirements, how to go beyond changing MCO behaviors, not just through contract requirements, but increasing provider participation in value-based purchasing and on alternative payment models. There's lack of data and reporting issues between health plans and providers. And also the struggle is, how do you evaluate the impact of value-based purchasing? Who gets credit for moving the needle? So I want to talk a little bit about your experience, both as a former Medicaid director and now the time that you've spent at Sellers Dorsey working with clients across the country. So thinking about your previous role, what were some of the biggest challenges you've experienced as a state Medicaid director implementing value-based purchasing initiatives? What kind of strategies did you deploy to address these types of challenges? And Lisa, I'm going to start with you.
Okay, well, great. I think one of the key things that we found as we were looking at value-based purchasing strategies, a lot of the providers were really not sophisticated to take on risk or really understand what value-based purchasing actually meant. Even some of the plans were in the very beginning stages of trying to roll some things out. And so, you know, the notion of being prescriptive versus not prescriptive really did come into play because providers wanted prescription and plans wanted the flexibility to be able to test things out. And because there just wasn't enough information, and you know, the sophistication levels varied between, you know, large health systems versus, you know, single practice physicians, we ended up allowing for it to be a little more flexible just to see what would work. And with the notion that once we saw what was available and how providers were taking up value-based purchasing, then we could look to be more prescriptive. Things around patient-centered medical homes, for instance, ended up being a little bit more prescriptive from our perspective than maybe some of the other types of providers that we had. So I would say that was a huge challenge, and just provider willingness to take on that risk. And the data sharing was also a significant component related to this. Knowing what data to share, who could share it, how it would be shared, were all kind of the challenges that we were facing. And I think where we tried to go to address some of those is, add a little bit more specificity to our managed care contracts around what MCOs had to do in terms of data sharing requirements, and what types of data they actually had to share with providers in order to move forward with value-based purchasing. So it was, like I said, it was very much in the nascent stages at that point. I think there's been a lot of movement since that time, even since I've been in the Medicaid director's role. But I know my colleague will certainly have other things to offer as far as what strategies they offered.
Thanks, Lisa. Barry, do you want to add anything?
Yeah, I mean, Lisa covered almost all the things that I probably would have said. I would say, sort of adding on to the resistance from providers, not just because maybe they, weren't sure if they could take on risk, but also the fact that if there wasn't more money, right? Sort of this idea that it would eat into sort of the base funding that they were going to earn. And so I think that has been, one of the biggest challenges. We've had success here in California because we've been able to implement programs that did add money, right? So we have a quality improvement directed payment program with our public hospital systems in the state. And that was built off of our 1115 waiver that had a quality-based payment. And that has been very successful because it was more money, right? So it wasn't eating into the base. And it was a way to sort of encourage folks to take on value arrangements because they knew they could potentially have access to increased money. And so we've had a version of that either through the waiver or through this quality managed care directed payment program now for over 10 years and have really seen improvements in these measures with these providers, substantial changes in quality outcomes, access to primary care, all of that kind of stuff. We did add our smaller public hospital systems, our district and municipal public hospitals, about 6 years ago to these quality programs. And that was a different challenge, even though they were in the same program, because they were less sophisticated, oftentimes very small, very rural, very different from a Los Angeles County health system, for example. We had to tweak things to make it make sense for them and the community that they served. So lots of interesting things there. I think, going forward, the state is looking at trying to implement APMs with FQHCs and, really try to drive change there away from sort of the, fee-for-service model to something that really is rewarding outcomes and behavior. And so that'll be interesting to see as they continue to move forward in that. It's been a many-year effort to get going on an APM with FQHCs. So I think that's all I got.
Yeah, I think you covered a lot of the feedback and really addressed some of the challenges. I mean, making things prescriptive versus organic, providers struggling really around not having enough members they serve or enough clients to even bear risk across these settings. And to your point, Mary, we've seen a lot of work around hospitals and large physician practices, trying to create models that address long-term support providers, et cetera, have been a little bit slow in the making. And some of it's related to measures and, documented and measures that you can really track on. But it's great that there's so much happening. And I know this is going to be an area we'll continue to see tremendous growth in. So to this point, and related to value-based purchasing, what advice would you give to MCOs, providers, health solution companies to help states advance their value-based purchasing goals? And Mary, I'm going to start with you.
Sure. I mean, I think the first thing, and I don't think this is unique to California, but because we have so many plans, the willingness to collaborate with each other so that providers in the same service area aren't having to participate in vastly different, quality improvement or value-based or alternative payments and have to, maneuver around those different requirements, and instead really try to have similar programs in that service area so providers are able to focus on the things that the plans want them to focus on. So I think that's really important. I also think working with the state to identify, common goals or focus areas so that there can be demonstrable change across the state, that can be measured, right? When you have so many different programs with different plans and different providers, it can be really hard to measure whether they're successful because they're on such a small scale and they're all sort of doing things differently. And so I think trying to come together with some, not saying all, but some things that are statewide, I think will really help to demonstrate the value and how it can really help both providers and plans and the state achieve goals that then I think will encourage people to want to participate more. And then finally, I do think, thinking of plans, but also providers and other organizations, continuing to develop those technological solutions to improve data accuracy, data exchange, and even the clinical information, right? So a lot of times data is much more administrative and not very clinical. And a lot of times, right, these measures do require sort of the clinical component to measure whether things are changing. And so I think if they're continuing to be improvements in those types of technological solutions will really help enable this to become more widespread.
Yeah, I think those are really good points. I think providers won't be successful if they don't have real-time data. They can't wait to be surprised at the end and find out whether or not they've been successful. And if there's one thing we've heard more than anything, it's providers having to pick and choose which MCOs they're going to work with in value-based purchasing because the measures are different and the metrics are different and the level of administrative burden is different. And really, we should have all providers kind of rowing in the same direction and all MCOs really trying to support common structure, common goals. We use the term proprietary a whole lot, but really at the end of this, much of this is not proprietary. Having clear understanding of metrics and measures and goals are something I think that systems can achieve. And I think many of us started in this space kind of like, we really don't know. We're going to try it out. And we gave MCOs lots of flexibility, good, bad, or indifferent. Now, some of the feedback we get is if you'd been a little more prescriptive on the front end, we wouldn't have had so many desperate systems. So I think the feedback's great. Lisa, do you want to add anything there?
No, the only thing that I would add is coming with collective solutions among all the partners is absolutely, a great way to showcase what is and isn't working across these programs. And I think you need to tell the story. So when there are successes, being able to come forward as a collective group to say, here's what we've been able to accomplish. And, that helps move the continuum across all states. Everyone's looking at everyone else to see what's working and what's not working. And when you find those successes, being able to share it collectively, I think is really powerful.
I couldn't agree more. There's no need to recreate the wheel, across the country. Replication really, there's great success in identifying those best practices. Well, I want to move to another topic. And this topic has become probably the most controversial topic across the country. And rightfully so. It's large amounts of money. And, if you miss your opportunity, it can be many, many years before it comes back again. But that's around managed care procurements. And so I believe managed care procurements present an opportunity for states to really make major reforms to their Medicaid managed care programs. State managed care procurements are becoming increasingly competitive with higher and higher expectations on MCOs to not only administer program benefits, but address health equity and other population health issues. And we continue to add and add and add to those in terms of expectations and goals. Well, as consultants, and it's great to be on this side now because we've got to see this in multiple states, but as consultants, we have the benefit of seeing trends across many state Medicaid programs. And so I'd like to ask, and Lisa, I'm going to start with you. What are some of the key trends that you've been seeing in managed care procurements nationally?
So I think you hit on a couple of those. The focus on health and racial equity are significant areas of focus right now. The requirements for multicultural healthcare distinction certifications for MCOs, requirements around social determinant of health screenings and assessments, and then referrals. Some states are requiring, specific vendors to be utilized. Others are allowing more flexibility, but having a requirement that it actually be accomplished and that they can demonstrate through the MCO that it has been accomplished. And the push towards integration of not just your traditional physical health services, but more behavioral health, long-term services and supports, and interactions with those community-based organizations that help that person across the continuum. So I think those are some of the key things that we've seen. We've talked on value-based purchasing, but I think now what states want to see is not just value-based purchasing in a traditional physical health environment, but bringing that more in line with behavioral health providers and LTSS providers, and maybe even some of the community-based providers around a full package of services. So, there's a lot happening in this space, and different states are trying different ways to approach it. But I think those are some of the key things that we're starting to see in MCO procurements across the country.
I agree, Lisa. And I'd say that having spent a long time in this system, I would say all three of us have spent a lot of time here. It's great to see the focus so much more on other needs of the member outside of just acute care needs, and really trying to support that individual and their family in some cases to really deliver care in a meaningful way, and that really has the potential to help them achieve these outcomes, and for many of them, independence. Many, from social determinants and other supports, eventually leave our Medicaid system. But we know that it's the actions of the MCOs and community partners and providers that are making that difference. So Mary, I'll ask you, do you want to add anything to Lisa's comments?
No, she covered it all, so I'm good.
Well, we'd expect nothing less from Lisa. But I do want to ask, I want to ask you a question, Mary, specifically as a former state Medicaid program administrator. What is the biggest piece of advice you have for managed care organizations trying to position themselves for success in current managed care procurement environments? And what would you say to providers and other healthcare solution vendors and partners who might be listening?
Sure. I think the number one thing is knowing what the state's priority areas are and initiatives. You have to be able to demonstrate how you can further those. For example, and particularly if you're not an existing Medicaid plan, right, in the state. So the state doesn't know you. They don't know if you know what they're doing. So I think really making sure you're doing your homework and understanding what the state's vision is for the future. For example, in California, we have the CalAIM initiative, which is really focused on the whole person care, right? The social determinants, and plans are able to voluntarily offer in lieu of services that are community supportive, such as housing navigation, recuperative care, meals, that kind of stuff. It would be important for someone to know that not only are they voluntary now, but that the state's ultimate goal is for some of these services to become covered benefits. So being able to demonstrate that you could provide these services, provide them in an integrated fashion in the community, would likely be super important to our state in selecting plans. And so really understanding where the state's focus is and what their vision is sort of over the next 5 years, not just what they're doing today, but what they've said they're planning on doing. I also think it's really important to know how the state measures success. How do they evaluate plans? And demonstrating that you have done that elsewhere, if you're not a current Medicaid plan in that state, so that they have some confidence that you're going to be able to take care of their population. And then finally, and I don't know if this is different in different states depending on how big they are, but here in California, I would say having a local presence in the community where they're going to be serving those members is also a really key factor. here in California, we have non-commercial plans that are local entities, and those are not reprocured, right? We only reprocure the commercial ones. And really what we've seen is those plans have higher quality, they have better outcomes, and people choose them more. And I think a lot of that has to do with their local connection. And so one of the things is, if you're coming in as a commercial plan, what is your commitment to that community? And knowing what that community needs and having a local presence so that people believe you're there to serve them and not just to sort of, make money. So I think those are the three main ones that I have.
Yeah. Well, what would you say to providers or healthcare solution partners that are trying to align themselves with managed care companies to support states' goals as part of these procurements?
I think it's the same thing, right? Demonstrating how you can help that plan be successful in achieving those things that are the state's priority initiatives. So if that's helping, as a provider, how are you connected with the community? How are you connecting with those CBOs who are providing those social services? If you're, some other type of vendor solution, how is that aimed at improving that, data exchange or being able to connect folks to those social services? So I think it's still the same things, which is be totally bought into what the state is trying to accomplish and help the plan see how you can help them be successful in that.
I think that's great. I think a lot of plans spend a lot of time focusing on differentiators, and I think that's great. I appreciate the opportunity to say, oh, you're going to go above and beyond. But I know from experience, and you too probably have seen even in your own respective states, that sometimes the managed care bidders don't even address the basic minimum things. They really focus on things to try to stand out at the risk of not really even building confidence around their ability to carry out the basic contract requirements. And I always say to MCOs, these are major, major investments. And these Medicaid directors and their staff really putting their confidence in these managed care organizations' abilities to meet these standards and to achieve outcomes on behalf of these members. Those decisions are not made lightly. We know there's high risk for protest. And at the end of the day, we have to ensure that the people that we're passing capitation to are really the best and most capable of affecting the type of change and coordination for members. Lisa, do you want to add anything to this particular?
No, I couldn't agree with both of you more, and all the comments that you've made, that's spot on. I mean, this is what the expectations should be for folks that want to participate in these types of programs.
Great. Well, Lisa, I've got a question coming up for you, and we're going to now shift to ongoing managed care oversight. And we know across the country, this is a really hot topic. There are lots of states where managed care is not well respected, and we know that there are countless requirements that states are imposing and restrictions and mandates for managed care companies to meet. And so as state Medicaid programs seek to strengthen their program requirements for managed care organizations, they have to be able to provide proper contract oversight in order for the requirements to be effective. And we know it's not helpful to ask for 30 things that the state never ever looks at, just because somebody thought it was a good idea. But so Lisa, I want to start with you. And as a former Medicaid director, what were some of the biggest challenges you experienced related to managed care oversight?
So I would say the first thing is really the change in the role of your staff, especially when you're transitioning from a fee-for-service environment to managed care. It's different. You become a contract manager versus the actual person who's reviewing and authorizing services, perhaps, and making sure that claims are being paid. Now you're actually enforcing a contract on a large organization, and just having the capacity to change that function and that role is difficult in many instances. I think trying to create the technical assistance and the tools for staff to be able to make that transition was extremely important, so that they know this is what's expected. These are the things that you should be looking at. These are the questions that you should be asking for your MCO. There were instances where, we created tools and then the tool became the job, like populating the tool was the job. No, that really wasn't the job. The job was really to use the tool to analyze what was happening and then be able to adjust accordingly. So I think, having the ability to create some of those tools and dashboards for folks so that they could quickly grasp what that change looked like, I think that really was important for folks.
I agree with you. I think that when we move to these systems of oversight, as opposed to having staff that were doing this work previously, really the confidence for the teams to feel like they can effectively provide oversight, they need the tools to do that. And sometimes it's the staff and the caliber of staff you need. If you are going to be managing clinical oversight, then you need to have clinicians. And if you're going to be really spending time managing financial outcomes, then you really need people who are qualified on the financial side. And I look back and I think that some of these contracts, depending upon the state, are worth billions of dollars. And if you really think about what it takes to provide effective oversight for $1 billion contracts, it takes resources. It takes sometimes change. As you mentioned, change management is a key component of this. But I think it also means that you really focus on what are the most important requirements, and that you can't write a 1,000-page contract packed with requirements only to implement and then half of them not be regulated or overseen. And so, Mary, I first want to ask you if you want to respond to Lisa, but then I want to ask you a separate question.
No, that was the main thing I had, is that staff need to have the knowledge and understanding of what they're managing. And you have to have enough people to do it, right? Particularly in the state of California, we have 26 plans, right? So we needed a lot of people who can know what they're talking about. You need the auditors to know what they're doing. So yeah, to me, the staff issue is the largest one.
Yeah, and I think states think, well, we're giving this business to managed care organizations. They're responsible for it now, so we don't need as much. But the reality is, to do this effectively, you need just as much or more, but maybe a different type of resource. Mm-hmm. So I think we're all in agreement. Having run big systems, we know exactly what it takes. So I want to ask you, Mary, when we think about administrative burden, and I want to be clear, we're not trying to suggest that when we talk about administrative burden, it's just MCOs that argue that they are facing administrative burden. We know we hear from providers, we hear from stakeholders, we hear from families. And so I want to counter that I'm not trying to suggest that it's just managed care companies that might argue they are facing some administrative burdens. So as a former Medicaid director and now somebody who is providing assistance with these types of things, what do you think a balanced approach looks like to managed care oversight that balances accountability with administrative burdens and some of the things we've talked about? And Mary, I'd like to start with you.
Sure. This one's actually a really hard one for me, because our experience was that if we weren't tracking and holding plans accountable for everything, they didn't focus on those things. And they had really much worse performance in those areas. So for example, we hadn't always held plans accountable to all the CMS core measure set. We had a subset that we focused on that sometimes changed every year. But then we were looking at their performance on all of the measures, and in particular on the child measures, we had maybe had half of them that had been sort of had, specific performance requirements and potential for, corrective action and sanctions. And the other half had not been, and they were terrible. The ones that they were not required to sort of be held accountable to were well below what was acceptable. So much so that there was a state audit of the Medi-Cal program saying that we were doing a terrible job with sort of childhood outcomes, and they were right. I mean, it was accurate. So, we did change, and we now hold plans accountable to all the measures, and we see improved performance. And we've had other examples, like with encounter data. Our encounter data was terrible. really, like, we had to do a lot of supplemental data to do rate setting, to do lots of other things. And so once we started doing strict enforcement, including penalties, we saw improvement. I think I would hear the most from plans when all of a sudden we would, say we're going to financially penalize you. And then all of a sudden they want to take action on these issues that we have raised for years, right? So it's a little hard for me to say what a balanced approach is when we tried that and it didn't work. So in my mind, the only real way to have a balanced approach is if the plans are cooperating and there's a real commitment to meet their entire obligation, even if they're not being measured on it. And so I think, that is a hard conversation to have. And I think if I was still at the state, I would only be willing to consider sort of reducing some of the burden if we had seen sustained performance, and we would check, right? And if we did, and then things started going down, I'd probably never go back again, right? Yeah. And I think the other thing that I think would help at least reduce the burden without actually reducing the accountability is improvements in that data exchange and capacity for clinical data that I mentioned earlier, because that can then help reduce the need for this supplemental data that you'd have to submit. So I'd really encourage, plans and other sort of technology companies to really help create those solutions, because then you're not reducing accountability, you're just reducing the burden.
Yeah, I think that makes great sense. I think back to time spent by even staff within my Medicaid division that were having to do data entry of data from health plans, et cetera, because there wasn't the ability for that information to be provided in an electronic format. Yep. And, then to provide oversight. So for step one was recording it again. And then step two would be, what do you do with the data? I think the other thing too, and Mary, I agree with you completely that in any of these contracts, what you pay attention to are where your contractors will focus. And I think that's critical. I think one of the things that we've seen, it's some states have done a review of their contract and have said, we have, I'm just making up numbers, but we have 10,000 requirements in the contract. 1,000 of them, we have no idea where they came from. They might have come from a legislator 15 years ago, and we added this because, the agency was, humiliated in front of a legislative committee or something. But there is this need to go back and make sure that what you're holding these plans to is still relevant and still makes sense. But I agree with you completely. It's hard to decide where you move the needle, because your advocates for children are not going to be happy without providing oversight. Likewise, if you make movement on adults with disabilities or children with disabilities or alike, there's always going to be somebody who will have an issue with that reduction in oversight. So it is definitely a challenge. And we know that the requirements grow every day, every legislative session, the federal level, the state level, it's constant churn. So I appreciate your feedback. Lisa, do you want to add anything to that?
The only thing that I would say is, the areas where it affects the consumer, I think is really some of the most critical areas. Like, the focus is really for the program around quality, access, and financial accountability. And those tended to be the areas where you make sure that you're actually collecting the data, you're actually looking at it and doing something with it, and making sure that your plans understand that as well. So it could be various initiatives that you have, and trying to gather that data on the various initiatives and decide like what's the most important thing that moves the needle on those things, I think is really where you tend to focus, and try to stay away from those things that really aren't as critical as you both said. So yeah, I couldn't agree with both of you more.
Well, so that's the end of my questions for today. I want to thank both of you for sharing your wisdom, and certainly your passion shows with the decades of experience that you have in leading Medicaid, but not just as an administrator, but as somebody who cares deeply about the purpose and the expectations and outcomes. I want to thank you both for spending a few minutes discussing these topics, and I can't wait to see you guys in person again. For our viewers, we hope you enjoyed the discussion today. We would encourage you to reach out to our team if we can ever be of assistance to you or your organization. And please keep an eye out for additional webinars in our Medicaid Matters series. Thank you so much for tuning in.